So if we look at the epidemiology of HIV, we have approximately 1,800 cases diagnosed with a total prevalence of 0.1% and above 1,000 new cases per year. HBV prevalence is from 2 to 4%, depending on the count and depending on the diagnosis. And HCV antibody prevalence is from 0.9 to 1.9%, with estimated amount of 320,000 patients, and approximately 200,000 of these would have HCV RNA detected. In terms of co-infected people, there are not very clear data, but we estimate that approximately HIV-HBV 30% to 40% is anti-HBC positive, but the replication of HBV is noted in approximately 1% of course, untreated people, and co-infection of HIV-HCV in approximately 1/3 of HIV-positive persons. And I will go into the detail of every of these viruses, which we were requested to present. So in terms of HIV, there is an increasing number of new cases, and we say that HIV infection in Poland is expanding, and that there is a major shift from IDU infections, IDU transmissions in the 80s and 90s to the sexual epidemics at the moment. And this is mostly MSM epidemics in large cities like Warsaw, Wrocław, Gdańsk, and Poznań. So we see this, even some people say geometric increase in MSM populations in the last years. So there is a decrease in co-infection, and this is like historical observation data from the cohorts. So we see in HIV-HCV co-infected people that most of these would be IDUs, a little bit of MSMs, and this frequency is increasing in the last years, and heterosexuals are mostly IDU partners, so this would be females. In terms of co-infection HIV-HCV, we would have from Eurocida the calculation of 34%, but look what's going on if you look from the year of diagnosis, and these are HIV-HCV co-infected people from 1990s to the present data. So these are people who have been the co-infection status at diagnosis. So in 1990s, mostly there was HIV-HCV co-infection diagnosed as a new diagnosis, and there is hardly any at the moment. So this is a reflection of a shift in epidemics, what I have just said, from IDU to sexually transmitted epidemics, and mostly MSM, which is a blue bar, and vertical infections have been declining. There is now a screening program with obligatory twice testing in every pregnant woman. So there is an obligatory testing in the 10th and in 34 to 36 weeks of pregnancy. So this has decreased the frequency of vertical transmission of HIV. If we think of current HCV epidemics in Poland, so we see that actually this is the epidemics which is mostly prevalent in 40 to 60 year olds. So there are not many cases in young people when the screening program was introduced. There is increased mortality, observed increasing mortality in terms of HCV, and the number of cases diagnosed so far ranges between 30 to 50,000, depending on the epidemiological study, and the fluctuations of the number of new cases per year are related to the screening campaigns, and at the moment there are from 2,000 to 3,000 cases diagnosed yearly. If we look at the HBV issues, so we can say that this epidemic is controlled. And actually, from the point of view of epidemiology, there was in 1993, 1994, expanding campaign to vaccinate all the neonates, and now it's in the obligatory vaccination calendar, so all the neonates from this period are vaccinated. When in 2000 the campaign to vaccinate teenagers started, so there is a declining prevalence and there is hardly any new cases, less than 100 a year. And what you could see from the incidence by age, if people are below 15 years of age, there is hardly any cases, and the chronic Hep B is in the older individuals, and the incidence is stable, so there is no rise in this. If we look at the subtypes, HIV epidemics in Poland is largely subtype B, and it's 85%, 86%. 95% subtype B in MSMs, and there is no shift from subtype B to non-subtype B in this population. And we have some imported non-HIV, non-subtype B cases as well, mostly A1, some Ds, and some CRFs. In terms of HCV genotype distribution, this is 1B country with a lower number of genotype 3 cases and tiny percent of genotype 4 and genotype 1A. If we look at this subtype distribution in HIV, so this is what we are looking at as well. So this 13–15% of subtype of non-B subtypes is mostly A1, and there are some novel recombinants which occur only recently between A1 and B, which are localized in one city only, and these are probably sexual mixtures because all these people are either heterosexual or MSMs. So we could see this recombination going on in the country as well. And we have been import tracing some of non-Bs which actually come from the Eastern Europe. Some of them, like subtype G, come from Portugal, and subtype C is mostly imported from Africa. It should be noted, though, that these are all Polish people, these are all Caucasians who have imported the virus back, but Poland does not have a lot of immigrants, especially infected with HIV, and we could even trace exactly the region of the world where our HIV is coming from. This is only for non-B cases. In terms of genotype distribution among HIV-HCV co-infected people, in Eurocida historically, this is 50–50 more or less, first genotype and the third genotype. And if we look at the exact cohort data, it's very similar, 35% of 1B. This is for our cohort, and the data from Professor Hoban's group, and then the genotype 3, which is historically, again, from IDU, associated with IDU transmissions. But if we observe our MSMs, they would be mostly genotype 1 infected, and I will show that in 1 second. Main factor for transmissions, as I said, this is mostly MSM epidemics in terms of HIV at the moment, but in the observed patients, there is still a major proportion of IDUs. And we could see that because these people survive for long periods. And this unknown in HIV is the underreported probably heterosexual and MSM, because not everybody is disclosing the route of transmission. In terms of HPV, there is no exact percentage available, and this epidemics, this issue is probably the least certain, probably mostly sexual, a little bit of IDU, because as we see, the IDU in Poland is declining. And in HCV, nosocomial infections are historically and currently the predominant route of transmission. After 1992, it's only 7%, but before 1992, it was 27%. IDUs amount from 5 to 9% of the new HCV cases, and we observe the increasing MSM prevalence in some large cities again. And if we look at this data, these are the new data, which I presented before 3 days in Łódź in our national conference, but which are calculated only 1 week ago. So these are NS38 sequences from genotype one HIV-HCV co-infected patients, you could see in blue IDUs which cluster together, and they are mostly 1B. And you could see also 1A, 2 cases of transmitted, probably, Q80K drug resistance. So this would be Cimeprevir resistance, and also a cluster of 1A MSM transmissions. So all these are epidemiologically very closely linked together. In terms of treatment availability in Poland, so in HIV, all approved treatments are available, including all the single tablet regimens. So we have full availability of all the drugs, basically depending on the local tender. So maybe there is 6 months delay or 3 month delay, but everything what is registered is available for our patients. In terms of HBV, tenofovir, lamivudine, entecavir, adefovir, and interferon. Also, lamivudine and tenofovir are generic at the moment, so they are available both in the as an original and generic. And for HCV, in terms of the national provider treatment program for status for May 2015, we have available Cimeprevir in combination with pegylated interferon and ribavirin, telaprevir and boceprevir. Another DAAs are probably coming soon, but this is the state for now as registered and refunded, and I'm not speaking about expanded access or salvage therapies, which are kindly provided by some pharma companies. As I said before, HIV epidemics is approximately 18,000 people, probably 1/3 or 2/3, depending on the estimates, are undiagnosed. If we calculate it, it would be only 45 of these treated cases on heart, but it's not very true, because we would say that all the MSMs would suppress, most of the IDUs would, and most of the heterosexuals. And also, I would have to say that treatment is available for all the patients who come to the care, who decide to treat themselves, so there is no limitation, no waiting list, and the current threshold for treatment is below 500, and all the other prerequisites as stated in the EACTS guidelines, and we have our own Polish Society guidelines which regulate that and which are updated per year. Transmitted drug resistance is not very common. It's less than 9%. It's stable over time from 2008, and it's less than 10% in MSMs. So we could see that this is the issue to be checked for, and most of our patients have a baseline genotyping performed at diagnosis. In terms of HBV, these data are probably the most vague because they are not very collected as the epidemiological problem declines. 30% probably are on therapy, and most of them would be on nucleoside or nucleotide analog, and the number of cases of death are estimated only as 90 per year, but this estimate is very rough because most of the deaths are reported as hepatitic causes, so they are reported together. In terms of HCV, the data are better, so we have approximately 3,000 new cases diagnosed per year, which is amount of not more than 50% of all diagnosed. Historically, 20% of these only received protease inhibitors. Now, from this year, the program is expanding, and percentage treated and cured, the treatment efficacy is 40% for genotype 1 and 4, and 70% for genotype 3. And the number of deaths, as I said before, is increasing. We perform liver transplantation, approximately 300 liver transplants per year, and 1/3 of these is from hepatic causes. In terms of treatment issues for Hep C, so we would say that we treat approximately only 2% of total infected cases. Viremic prevalence in the total population is 0.5%, and diagnosis rate currently is 15%. And mortality is divergent from region to region, and it's increasing, and the transplant centers have slightly smaller mortality. So there is a scale-up for DAA treatment necessary in this context. So in conclusion, the epidemics of HIV in Poland is expanding, and it's underdiagnosed, especially in the MSM. So we still see quite a few number of late diagnosed cases. There is full treatment access, but there is an MSM population who gets infected. So the challenges are prevention and treatment as prevention, early testing, in some population linkage to care, because retention in care is not that problematic. HCV is largely underdiagnosed with limited access to DAA so far, but we hope for improvement. And treatment mostly either classical PEG-RIBA or PEG-RIBA plus protease inhibitors, anti-Hep-C. And of course, challenges testing and detection of new cases, interferon-free treatments, and whom to prioritize for the novel therapies. And HBV is basically controlled. The vaccination coverage at the moment is very high in neonates, and our country is controlling the vaccination quite well, full access to nucleoside and nucleotides as necessary. So probably this would be only the chronic care and detection of HCC. So thank you very much, and greetings from our northwestern German border city with a large port and tall ship races held every few years. Thank you very much.